Chest Tube Insertion by Carla Kate Cueva. Chest tube insertion is an essential skill for hospital doctors dealing with certain pleural diseases to drain the pleural space of air, blood, chyle, pus, and any other fluid. Chest tube insertion is indicated for patients having pneumothorax, hemothorax, pneumohemothorax, subcutaneous emphysema in patients who sustained chest wall trauma, and empyema. For the materials, we will need a cut-down set, sterile gown and sterile surgical gloves, a glass bottle system with underwater seal, chest tubes at least 28 FR, povidone iodine antiseptic, sterile sponges, silk O with curved cutting needle, syringe with local anesthetic, vaselinized gauze, plaster, a rib cage model, a set of towels, and towel clips. Using the syringe and the local anesthetic of choice, prepare it beforehand while observing safety and sterility. Procedure. If possible, have the patient assume a semi-upright position with the arm placed above the head. Next, prep the skin over a wide area of the chest wall with povidone iodine. Remember to do it in an outward concentric motion. Drape the area with 4 towels and not with a single fenestrated sheet. Start with the area nearest the surgeon. Then proceed cephalad, caudad, and lastly at the side away from the surgeon. Secure the drapes using the towel clips. Palpate for the 4th or 5th intercostal space at the anterior axillary line. Infiltrate the skin with a local anesthetic and block the intercostal nerve branches. Do not forget to infiltrate the pleura. Make a 2.5 to 3 cm long skin incision well into the subcutaneous tissue. The insertion site of the chest tube should be as close as possible to the upper border of the rib to minimize the risk of injury to the nerve and blood vessels that follow on each lower border. Insert a curved Mayo scissors or curved Kelly clamp and cut or separate the tissues so as to create a tunnel or tract in the direction in which the tube is to be inserted. This tract should be directed posteriorly, cephalad, and medially so that the tube lies posteriorly in the paravertebral gutter. Continue developing this tract all the way into the pleura. Remove the scissors or clamp and explore the tract with a gloved finger from time to time to make sure that the tract is going in the right direction. After the pleural cavity has been entered, insert the gloved finger to explore for adherent lung and then further enlarge the opening in the pleura by inserting a large Kelly clamp and spreading it. Select the tube to be used. Note the location of the holes and the distance of the proximal hole to the tip of the catheter. grasp the tip of the tube with a long Kelly clamp so that the long axis of the clamp is almost parallel to the long axis of the tube. Measure the distance and note or mark with another smaller clamp. If hemothorax is suspected, it is also advisable to clamp the very distal end of the tube to avoid making a mess. Insert the tube into the chest using the large Kelly clamp as a guide. Remove the large Kelly clamp as soon as the tube reaches the desired position in the chest, but do not remove the smaller clamp marking the point of emergence of the tube. Palpate to ensure that the tube has entered the chest. Suture the tube into the skin with Silk Zero. Pass the stitch around the tube to close the wound margins. Tie the suture in place tight to the skin. Now, wrap the ends in opposite directions around the tube to form a series of X's. Push the suture down to the skin again before tying to prevent slack from being incorporated in the suture. Only after these sutures are placed may the smaller clamp on the tube be removed. Connect the tube to the underwater seal chest drainage system. Care should be taken to do this step properly as this may cause pneumothorax if the tube is disconnected from the underwater seal. You may place additional stitches around the wound. Place Vaselinized gauze dressing around the tube and push it with one hand to prevent air leak. Next, place the 4x4-inch gauze and create a slit at the center. Place them 90 degrees relative from each other to avoid slipping. Secure the gauze using the plaster. Obtain a post-tube insertion chest X-ray to check the position of the tube.